Can you see the slide?
Yes.
Yes, I'll start. Good morning, everyone. My name is Eunju Jung in Department of Surgery, Yonsei University, South Korea. Today, I'd like to talk about how to manage the complicated wound in surgical hospitalist system. First of all, special thanks to my colleague, Professor Min-young Park. In the surgeon's aspect, wound care is the most basic of basics. All of certain things everybody can do, and it is very easy and very simple. However, now, is it really true? The complicated wound is difficult to manage. In general, complicated wound means with infection or complications, disease or eviscerations, or with disease progression, or with surgical complications with the leakage. These sometimes require surgical treatment. Importantly, complicated wound management needs sometimes diverse approach, including nutrition support or systemic treatment. In the past, surgical residents learned wound management from colleague or senior resident or faculty, as I did. Now, there are many experts working in wound care field. So most of the complicated wound care is performed by nurse practitioner or WOCN. Now, I want to ask, who can manage the complicated wound properly? Can you do this? How about in the future? I think many people have heard about the hospital medicine. This is a new field of medicine that deals with inpatient care. Also, we pursued quality improvement and economic effectiveness of medical care based on the patient safety. In US, this new system is started from 1990s. In the paper in New England Journal of Medicine, the hospitalist in US is over 56,000 on 2016. Now, over 80,000. There are many people work as the hospitalist in US. The number of them is increasing very quickly now. So now this is almost 8% of doctors in US. In Korea, this new field was started just 7 years ago, the 2016. Korea is still in its early stages. The word surgical hospitalist may be very unfamiliar. This figure shows the concept of a surgical hospitalist. In the past, surgeon was almighty, as I did. But in this new system, we make the team. The operator are responsible for operation mainly, and surgical hospitalist responsibility for preoperative and postoperative care. They form a close teamwork based on the confidence and communication between the specialists. So the role of surgical hospitalist is for clinically, they do the advanced primary care and perioperative care. Furthermore, education for medical student, resident, intern, or nurse, specialist, and research. And the most important role is in hospital system care. Let me briefly introduce the surgical hospital system at our hospital. The Severance Hospital is a mega hospital in Korea, the second biggest hospital in South Korea. We started this new system 7 years ago. But firstly, we started it at the surgery department. Now there are 8 surgical hospitalists and manage the 25% patient in Department of Surgery. You can see that the 2 big buildings. The one is the Yonsei Cancer Center. Second cluster is the Severance Hospital. So in this medical cluster, we have the 4 teams in upper GI, low GI, hepatobiliary, and transplantation. We provide inpatient care for daytime, including weekend and holidays, except the night. we can see our team's experience and subspecialty. And this is me. I have the 18 years experience surgeon, and my subspecialty is colorectal and trauma. Also, I'm the main moderator in operation of the surgical hospital system in our institute. From now, I'd like to show the few cases we did. First, the male 74 years old. He received laparoscopic anterior resection because of the sigmoid colon cancer. Postoperative 5 days, he complained the discharge from main wound on abdomen. I thought firstly, seroma. After open the main wound, I checked the distance of anterior fascia of rectus muscle on fundus incision. You can this. So we did the fascia close on the local anesthesia. It's very simple. The second case, the female, 72 years old. She received the laparoscopic ultra low anterior resection with the colon-anal anastomosis ileostomy because of the rectal cancer. She on the postoperative 8 days, she complained the previous hemorrhoid and the discomfort of anus and said, ointment please. But we can see the disrupted anastomosis. You can see this reddish tissue. This is the distal part of the anastomosis, and this were protruded from anus to outside. After the antibiotics and cispace, the wound was stabilized like this. You can see the improvement. And after 3 weeks, we did the transanal re-anastomosis was anastomosis and then discharged. The third case, the male 52 years old, he visited the ER because of the perineal wound discharge. He received multiple operation because of the metastatic rectal cancer. You can see the lower anterior, pelvic lymph node dissection, ileostomy repair, and the last operation was abdominal perineal resection with the liver wedge resection and subtotal sacrococcygectomy. This is the photo in ear. In ear, we can see the distance of the perineal wound. You can see this, and sacral bone exposed here, and peritoneal mesh exposed. You can see the small portion of the mesh here. The mesh is the barrier between the bowel and the extraperitoneal space. Anyway, there is some infection on mesh. First of all, we did the massive saline irrigation. And wound was closed with Jackson Pratt drainage insertion under local anesthesia like this. I did in the ward on the local anesthesia. However, as you expected, we failed the infection control. So we changed the plan. The wound was open and irrigation and soaking dressing was done. And then after infection control, MPWT, the negative pressure wound therapy was applied. So we applied this device with the low power apply because the mesh and above the mesh there is a small bowel. So we weren't worried about the small bowel injury. So we used this device with the low power. And for 4 months management, we tried diverse methods for wound management, including MPWT, aseptic dressing, debridement, soaking, and so on. After healing, infection control, but you can see the not complete healing. So he received a local flap operation by plastic surgeon like this. And next, the male, 51 years old. He visited the ER because of the pelvic abscess and high fever. He received the low anterior resection because of the rectal cancer. The complication, so-called the anastomosis structure was developed. So pelvic abscess was developed, and this is made the fistula around the coccyx. You can see the stool. Via cutaneous fistula around the coccyx. This is not anus, it's the fistula opening. On CT scan, the anastomosis site wall defect was connected with presacral, pelvic cavity, intermuscular space abscess. You can see the fistula opening on coccyx and the multidirectional abscess cavity. The first treatment plan was fecal diversion. So we did the double barrel transverse roof colostomy. And after the transverse colostomy, we did the multi-directional irrigation via coccyx and anus. So after the TID 3 times massive irrigation for 3 days in the world, the wound become clean and he discharged. And next case, the male 38 years old. He received the abdominal perineal resection and the parietal lymph node dissection, pelvic lymph node dissection because of the advanced rectal cancer. And after preoperative concurrent chemoradiation, his weight was 104 kilograms. He's very obese, and he had the paraplegia. Postoperative 6 days, wound was infected. You can see the ulceration and skin necrosis and infection. So we opened the perineal wound because of his obesity. This space is very big, about the 1 liter saline can fill this space. So massive saline irrigation was done, and we tried to close the wound with drain like this, with the celastic drain. But wound was improving very, very slowly, but it is not enough. So surgical hospitalist did the TID massive dressing with 6 liter saline with soaking dressing. After improvement, we applied the MPWT. Postoperative 44 days. You can see the granule tissue with the reddish, healthy. The granule tissue was grown up slowly, and dead space was smaller, very, very slightly. But skin necrosis, like here, is remained because of the immobilization, because of the paraplegia, obese, previous radiotherapy, and wound was slowly improved, you can see. And postoperative 69 days, you can see the dead spaces was smaller and has tissue and a small amount of necrosis. However, it is not completely. On 7 months, wound was not healed completely, but much improved without infection. He received the chemotherapy for lung metastasis. I think at this time, the chemotherapy delayed the wound healing. However, the most important thing is the oncological outcome. So we think about the chemotherapy is first treatment. However, he was died on 1 year, 6 months after operation because of the cancer progression. It is a sad ending. It's a last case. Female 66 years old. She received the colonoscopy polypectomy in other hospital. And the colon perforation was happened, so Hartmann's operation was performed in other hospital. Because of the complication, she received the reoperation and ICU care for 2 weeks, and then she transferred to our hospital. This is the wound status. There's many problem. It's a problem is the mainly evisceration with bile leakage on main wound via the main wound, severe weight loss about 15 kilogram, and malnutrition, sepsis, and so on. So we made the treatment plan like this. The first thing is wound care and intercutaneous fistula management, nutrition support for weight loss, and general condition build-up. And finally, we want to do the repair of the Hartmann's operation. So after 3 days wound care, it was stabilized like this. We insert the suction catheter into intra-abdominal cavity to make the controlled fistula. We use the diverse method, the soaking dressing, drainage like this, and MPWT apply and partial closure. So on hospital 7 days, wound was much better, beautiful. With the nutrition support, the wound was better quickly. On hospital 11 days, we closed the wound and made the controlled fistula with the Jackson-Pratt drainage. And hospital 14 days, she could start the oral diet. This patient was discharged on hospital 47 days after reversal of Hartmann's procedure. happy ending. We can see the importance of the combination, wound care and systemic care. We manage this kind of complicated surgical wound in the world. And also this is the wound in the severe sepsis patient, the leg, foot, and so on. This is the last slide, take-home message. The complicated wound care in surgical hospitalist system is comprehensive art, I think. With the surgeon's viewpoint, surgical hospitalists decide the appropriate treatment, proper systemic management, and surgical intervention. And by the practitioner, we can do the best management for complicated wounds. Thank you for your attention.
Working at Common Orthopedics Department at the Pegawan Area Hospital. So I did the study in Velamal Medical College, which is in Tamil Nadu, India. So I was a junior resident over there when I conducted this study. So my main topic was, what was the effect of isometric quadriceps strengthening exercise in knee osteoarthritis patient? So let's dive into the study. Before that, is everyone able to see the screen?
No, we cannot. Yeah, make it full screen here.
Okay. Is it clear, sir?
Yes, sir.
Okay. So before going into all the particulars, just brush up the basics. So what is an osteoarthritis? So an osteoarthritis is a non-inflammatory degenerative condition of joints. So it is characterized by degeneration of all the articular cartilages, and there is a formation of bone spurs. Let me show you what are those. So when you look at these joints, there are a lot of, when you look at the left side, this is a normal joint. And when you look at the right side, it is the osteoarthritic joint. So what you can see is, when you see the left side, there's a regular normal subchondral bone structure. There is a smooth cartilage surface. There's a there's a normal joint space in the left side. And when you look at the capsule, it's not inflamed. But when you look at the right side, what you can depict from this picture is there is a reduced joint space. And the left side, there is a smooth cartilage surface, but it is lost in the right side. And there is also a lot of bone spurs. We call this as osteophytes. When you look at it radiologically, what you can see is there's a lot of subchondral sclerosis or subchondral cysts, and there's a lot of osteophytes, like in the bone spurs, and there is also a lost cartilageous surface. So this is what gives the patient the symptoms of pain. Mostly patient presents the OPD with pain, and they also say of some amount of stiffness, not much more, and they also complain of deformity and restriction of movements. So my aim was to look out if the patient was able to improve their quality of life by using pharmacotherapy as well as an exercise. Because a lot of the patients, they neglect doing this exercise every day.
Dr. Mohammed, can you
switch
on your video, because we can't see you speaking. We just see one photograph of yours.
Oh, sure.
Put your video on left side bottom. On your left side bottom of the screen, you will see video.
Sorry, sir, I'm not able to look at the thing. Yeah, I can see it, sir.
Now we will see you. Wonderful. Very handsome. Very handsome.
Thank you, sir.
Okay, go and share the screen.
So why do knee osteoarthritis? Why knee osteoarthritis? So it is one of the most common musculoskeletal disorder these days, because in Indian space, we all do a regular labor, and most commonly what happens is there is a loss of knee strength because of these days lots of people are having a sedentary lifestyle. And what happened is there's a wastage of muscles, which is important in maintaining the strength of the knee joint. So when you look at a lot of people these days, they have the deficiency in hamstring mass. So I wanted to emphasize more on this quadriceps and hamstring ratio. So when you have a lot of hamstring ratio, the knee gets more strength than in the quadriceps. So this is what happens in these days because of sedentary lifestyle. When we don't use muscle, we lose it. Either we use it or we lose it. So these days, there's a lot of prevalence of knee osteoarthritis patient in both in urban and rural areas. I recently done studies in 2022 depicted that there was a 26% increase in the prevalence of knee osteoarthritis in urban areas and 16% increased prevalence in rural areas. And it is also one of the most common disability in elderly population. When you see a lot of elderly people, they all complain of, I'm not able to sit squatting when I go to loo, and I'm not able to sit with the crossed legs. I'm not able to climb upstairs, climb downstairs, and there's a lot of restriction of movement, and their quality of life is being impacted because of this disease. That's the reason I wanted to do something for them. So what did I do? So we selected a target population. So before carrying out the study, we obtained ethical clearance from the committee, and we obtained baseline data from them. And we taught the patient what they need to do, and we monitor the patient every now and then. And we obtain the data after performing this intervention. So let me discuss briefly about each and everything what we've done. So first, we selected a target population. Whom are the target population? They are grade 1 and grade 2 osteoarthritis patients. So these patients are selected from by my consultant. So we basically do a physical examination. We obtain history. We do a clinical examination. We do a radiological examination, and we grade them as grade 1 and grade 2, depending on the American College of Rheumatology classification. And we also choose patients who are less than 65 years of age. And we also select patients who have osteoarthritis within 1 year. So we also neglect all the patients who has all the inflammatory conditions like inflammatory arthritis or septic arthritis or any other arthritis apart from osteoarthritis. So how do we collect a baseline data? We collect baseline data by using KOOS scoring questionnaire. So what is KOOS scoring questionnaire? So it is a knee osteoarthritis outcome scoring questionnaire. So what it has is it has 4 subtopics. So the patient has a set of questions on his pain. The patient has a set of questions on his or her symptoms and how the osteoarthritis affects their daily living and how does the osteoarthritis affect their quality of life. So after obtaining all the questionnaires and all the data from the patients, we get an informed consent from the patient about what we are going to do. So we were planning to do, we were planning to give them an exercise, which is free exercise, and along with pharmacotherapy, which is mainly an analgesic, topical analgesic. And if the patient has severe pain, we go for an oral NSAIDs. So along with all the advice which is given normally to the control group, which is a medication and a lifestyle modification. Lifestyle modification is what we regularly advise the patient to lose the weight and take care of their diet and go for some walk. This is a general advice, and we don't emphasize on the exercise part. Whereas in exercise group, we ask the patient to do what the control group does, and we also advise them to do a monitored exercise sessions every week and every week. So these are the 3 exercises which you can see from the screen. So first one is a straight leg rise exercise, and next one is an isometric hip abduction exercise, and the third one is an isometric quadricep exercise. So let me tell you what we did in each one of the exercise. So at first, in isometric quadriceps exercise, we asked the patient to lay down in a recumbent position and ask them to move the towel underneath the knee. So by doing this, they contract the thigh muscle, and it helps them to make a muscle, a muscle memory to activate all those muscles of the thighs. the same thing goes for straight leg exercise. Straight leg exercise keeps the anatomical position of the knee, and it makes the quadriceps muscle to contract vigorously, and helps the patient to learn how to strengthen the knee. So all these things are basic exercise, but when you progress in this exercise with weight and all of that, the results were amazing. So after doing these interventions, we collected the data at week 8. So what did the patient have? So these are the readings that we got from the questionnaires after putting it in a statistical format. So what we find out was that the patient had a decrease in pain by the week 6, and the patient's symptoms started to improve after the pain started subsiding. The symptoms started to improve drastically after 8 weeks, and the quality of life and the activities of daily living were drastically improved. So even then, we were not able to follow up on every patient. We also had some patients lose from the study, but most of the people did follow up our study. So these patients had a remarkable results by doing these exercises, and we even started teaching every patient now to perform these exercises every day, even after 8 weeks, and they are really happy with what they can do right now. So that's it. That's my study. Then that's what's done by me. And now, do you have any questions for me?
Medial malleolus fracture. So coming to the introduction, tibial plafond fracture is defined by intra-articular involvement of distal tibia with metaphyseal extension. Distal tibia along with the fibula and ligaments around the ankle joint form the ankle mortise, which articulates with the dome of the talus. As you can see in the image on the right side, there is a distal tibia and fibula with the ligaments around it forming the ankle joint. The plafond fracture accounts for less than 1% of lower limb injuries and 3 to 10% of tibial fractures. Treatment of plafond fractures mainly depends on the fracture pattern and degree of injury. Coming to the mechanism of injury, which is mainly axial compression, which cause impaction of the articular surface proximally into the metaphysis, and it is also associated with the comminution of the metaphysis. Distal tibial fractures remain one of the most substantial therapeutic challenges that comfort the orthopedic traumatologist. Numerous features are responsible for this, but perhaps none are as difficult as accompanying soft tissue injury, which is frequently present in these cases. Rate of deep infection in open ankle fracture is approximately 5%. Pylon fractures are frequently associated with severe soft tissue injuries that alter the management plan. Because of severity of soft tissue injury and disastrous results of deep wound complications felt to be attributed to extensive surgical exposures and bulky internal fixation devices. External fixation emerged as a successful technique for decreasing significant septic complications. Coming to the mucormycosis, it is an aggressive fungal infection which is caused by gynekomycetes. The primary cutaneous form has better prognosis than deep invasive form, but it is still associated with fatality and long-term morbidity if misdiagnosed. Mucormycosis has growing importance because of increasing population of immunocompromised patients. It is a devastating infection with high morbidity and mortality rates. In general, it refers to infection caused by fungi of class Zygomycetes. As you can see in the image right here, this is a picture of a Zygomycetes with sporangium, sporangiophore, and sporangiospores. Extensor tendon injuries of the dorsal foot are common in setting of dorsal foot penetrating trauma. Extensor tendons of the foot are vulnerable to laceration as they are subcutaneous. As you can see in the image, the tendons of tibialis anterior, extensor hallucis longus, extensor digitorum longus, which are main extensors, are mainly subcutaneous. A thorough understanding of mechanism of injury is most important when first assessing a pylon fracture. The amount of soft tissue injury and degree of complexity vary widely from low to high energy injuries. In this case report, we study a case of 35-year-old man brought to the ER after sustaining compound injury to the right ankle. Coming to the case report, a 35-year-old man presented to the emergency with complaints of pain and deformity of the left ankle. Patient had sustained machinery injury to the left ankle. On local examination, there was laceration of about 7 into 2 into 2 centimeters present over the left ankle, anteriorly extending from medial malleolus to the lateral malleolus. Cut tendons of extensor digitorum longus, extensor hallucis longus, and tibialis anterior were identified. Ankle movements were painful and restricted. There was no distal neurovascular deficit. The immediate thorough wound wash was given in the ER. Wound dressing was done and splint was applied, and patient was immediately shifted for an X-ray of left ankle, AP, and lateral views. This is the image when presenting on the ER. You can see the cut tendons and laceration extending from medial to lateral, and you can also see the talar articular surface of the talus and the distal tibia. The investigations, X-ray of left ankle, AP, and lateral views were done, and as you can see, the X-rays they show distal tibia fracture. Tarsal and metatarsal bones were normal. Coming to the procedure, thorough wound wash was given, and patient was shifted to operation theatre for immediate intervention under spinal anesthesia on supine position. Wound wash was given using normal saline, povidone iodine solution, and hydrogen peroxide. Wound was inspected and cut tendons were identified and tagged. Debridement of the wound was done as it was an contaminated wound. As you can see in the image, the cut tendons of tibialis anterior, extensor digitorum longus, and extensor hallucis longus were identified and tagged. Fractures was reduced and reduction was confirmed under fluoroscopy. K-wire fixation was done for distal tibia fracture. 3 K-wires were passed from the medial aspect just above the medial malleolus. As you can see in the image, the K-wires were passed medially. Tendon repair for extensor digitorum longus, extensor hallucis longus, and tibialis anterior done using ethibond sulfur material using modified Kessler's technique. And below knee slab was applied with ankle in dorsiflexion. This is an image on the left side. Tendons were sutured using Kessler's technique, and on the right side, wound closure and the drain was placed. Post-operative exercise were done. As you can see, the fracture was reduced adequately, and we tried to maintain ankle motus as much as possible. Post-operative period. Post-operatively, patient was kept on IV antibiotics and regular dressings were done. On post-operative day 2, there was a discharge from the wound site which was observed, and the swabs from the wound site was sent for culture and sensitivity. This is a wound picture on post-op day 2. As you can see, the wound edges, there is a color changes and it looks little macerated. Inside looks normal. On post-operative day 7, sutures were removed and debridement was done. As you can see, the before debridement picture and after debridement picture, as we had to debride and bleeding edges were seen. Culture sensitivity report has revealed fungal growth of Zygomystis species. On KOH mount, fungal elements were seen, broad accepted branching hyphae was seen. On blood agar, fungal growth was present, grey-white cottony growth was present. Lactophenol cotton blue staining showed broad accepted hyphae with sporangia. This is a picture on the left side shows blood agar showing fungal growth, grey-white cottony growth. On the right side is a microscopic image showing hyphae, sporangiospore. In view of angioinvasive properties of Zygomystis, after checking renal parameters of the patient was started on injection amphotericin B with a dosage of 1 mg per kg under physician guidance. Injection amphotericin 1 mg per kg body weight was given for 4 days. Later it was converted to tablet posaconazole 600 mg twice daily. Patient was asked to continue tablet posaconazole 600 mg twice daily for 6 weeks. On follow-up, patient was kept on posaconazole tablet for 6 weeks. Wound dressings were done regularly. This is the wound picture seen at 3 weeks follow-up. As you can see, there is sufficient granulation tissue. At a wound picture at 6 weeks follow-up, the size of the wound has been decreased and the granulation tissue was seen. And this is the wound picture at 3 months follow-up, showing healed wound and the K-wires were removed. Coming to the discussion, mucorales are widespread in nature, subsisting on decaying vegetation and diverse organic materials. Diagnosis of cutaneous mucormycosis is made by culture or biopsy. The potassium hydroxide preparation of the biopsy reveals non-septate thick-walled KOH mount of mucormycosis, showing right angle branching of hyphae. Hyphae can also be seen on the tissue section, autoxin, eosin, and bromorium with silver stain. Post-traumatic mucormycosis is rare and underdiagnosed condition. Definitive diagnosis is hard to establish and it often requires invasive procedures such as tissue biopsy by histology or culture. Cultures of infected tissues are often negative, but when it is positive, identification to the species level is time-consuming and requires expertise. As similar thing happened in this case, as we sent the culture sensitivity on day 2, and we received the report after the POD 7. Luckily, the patient was systemically stable. Mucormycosis is uncommon and typically associated with patients who are diabetic or otherwise immunocompromised. Wilson et al. In their study have observed that cutaneous mucormycosis in healthy patients is frequently the result of trauma and occurs via direct inoculation of fungi into a traumatic wound. Although mucorales show minimal intrinsic pathogenicity toward immunocompetent persons, they can initiate aggressive and fulminant infections under certain clinical conditions. Ganesan et al. Has observed that the cutaneous invasive fungal infection occur in deep tissue wounds contaminated by environmental debris. Such wounds are caused by agricultural accidents, tornadoes, and blast traumas. These infections are associated with substantial morbidity and considerable death rate. Severity of cutaneous zygomycosis in otherwise healthy trauma patients with open wounds ranges from contamination to extensive necrotizing facial. A high level of clinical suspicion is important in trauma patients, especially in the presence of open wounds, soft tissue injuries contaminated with soil, even in the absence of immunosuppression. Serious soft tissue injury and wound contamination within agricultural environment appears to be a predisposing factor in the development of cutaneous mucormycosis in immunocompetent individuals. Complete or serial radical wound debridement of all the necrotic tissue is the single most effective management. Since the zygomycosis rapidly disseminates through vasculature, a wide zone of excision is required, and this is an important point as we have to look for systemic signs as the patient may go into septic shock. Management of zygomycosis comes secondary to extensive surgical debridement. Commonly used antifungal agents do not have any effect on zygomycosis. High-dose amphotericin B is a drug of choice. Despite improvement in diagnostic modalities leading to the early diagnosis and increasing therapeutic options, treatment of mucormycosis is still challenging. Liposomal amphotericin B is the most reliable antifungal agent. Adverse effects of amphotericin include hypokalemia, renal impairment, and infusion-related intolerance reactions. Azoles have no consistent activity against mucormycosis, but newer azoles such as posaconazole are effective. Posaconazole has shown good in vitro sensitivity against rhizopus, mucor, and other zygomycosis species. Hyperbaric oxygen therapy has been reported to be beneficial. Mortality rate of zygomycosis is around 50% due to angioinvasion. In conclusion, this study helps to understand that high index of suspicion, thorough wound debridement, and appropriate treatment are required to prevent infection following any compound injury. These are the references. Thank you.
Dr. Rahul, you dealt
Sir.
the topic pretty well.
What do you mean go down?
Your cursor, bring it down. Go to the extreme right. Can you find out where is your cursor? Perfect, you've done it well.
Yes.
Yeah, we can see it well.
You want?
Go ahead.
Okay, this is good.
Yeah, good.
Okay, so hello everyone. My name is Halish Shabragi, and I'll be presenting this case report titled Regional Anesthesia for High-Risk Patients Undergoing Total Knee Arthroplasty, a case report. So there's nothing to discuss. To exclude, we declare no conflict of interest. So total knee arthroplasty, it's a common procedure that is performed
by pressing on presentation. Yeah.
So it's a common procedure performed for patients with end-stage osteoarthritis.
Make it full screen. Correct. Go ahead.
Is this good? Okay. So for patients with end-stage osteoarthritis, it has excellent outcomes in relieving the pain and improving the functionality. And it's showed to, that has been shown over the years. So, however, some patients are at risk of complications based on their past medical history, which includes their high BMI or their cardiovascular.
Full screen again.
So,
Allah, make it full screen.
Okay. Is this good?
No, bring your cursor to the last symbol. Down, down, down. Go down. Yes, that's it. Now don't press anywhere else. Go ahead. You are correct.
Okay.
So the anesthetic modalities used for total knee arthroplasty, they have
Into
advanced
it
much
full
to
screen.
I don't understand what seems to be the issue.
Can you see 5 slides on the left side besides one big slide? It should not be that way. It should be only one slide. So you have presentation. Next to that symbol is full presentation. Down. Bring your cursor down. Yes. Now don't press anywhere else, but what are you doing? You stop sharing your screen.
I will try to do it again.
Share the screen.
Is this good?
This is good.
Okay. So there are two main anesthesia groups that are used. We have the general anesthesia and the neuroaxial anesthesia. So there was a recent meta-analysis that showed when you compare the regional anesthesia and neurological anesthesia, it had a shorter stay and fewer complications following total knee arthroplasty. So currently there is no study in the literature that shows the usage of regional anesthesia when both the neuroaxial and general anesthesia are contraindicated. So this paper presents a case report in which the patient underwent a mix of regional anesthesia modalities to achieve the complete block of sensory impulses to proceed with the desired surgical procedure, which is total knee arthroplasty. So for the case, this was an 80-year-old overweight male. His past medical history included type 2 diabetes, benign prostate hyperplasia, and hypertension. So he presented to the emergency department with bilateral knee pain, which was worse on his left knee for the past 2 months. And his physical examination showed bilateral knee swelling. For his x-ray, there was advanced osteoarthritic changes in both knees, which was more severe in the left knee. There was no fractures, dislocations, or any bony lesions in the x-rays. So after consulting orthopedic surgery, the patient was opted to undergo the total knee arthroplasty of the left knee due to his poor quality of life done by the osteoporosis. So this was his AP and lateral view of the left knee. Then he was referred for cardiology for clearance. His ECG showed atrial fibrillation, and the echocardiogram showed dilated atria, moderately severe mitral and tricuspid regurgitation, and there were some features of restrictive cardiomyopathy. For his elevated pulmonary pressure, it was around 50 millimeters of mercury. So he was considered from the cardiology side as moderate risk patient. For his medication history, he was on metformin, statins, vitamin B12. He was also on omeprazole, apixaban, and beta blocker, which is metoprolol. So for the surgical course, he underwent the total knee arthroplasty with only the regional block and minimal sedation. There was no usage of any spine or general anesthesia. So under ultrasound guidance, 0.75 of ropivacaine was used with 1 to 200,000 epinephrine, and these nerves were blocked in this order. So first, he was put in the lateral position where the sciatic nerve was accessed and blocked to 15 mL. And then in supine position, the lateral femoral cutaneous nerve was blocked with 5 mL. And then the obturator nerve was accessed with the legs in the figure of 4, and it was blocked with 10 mL of the mixture. And then finally, in supine, the femoral nerve was blocked with 15 mL. So he underwent the procedure with the medial peripheral approach, and he tolerated the procedure well. And lateral and AP X-rays were taken of the left knee after the surgery, which showed the implants to be in good position. And these were the X-rays after the procedure. So total knee arthroplasty, it's a safer option with more efficient outcomes and minimal adverse effects, and it improves the pain if the peripheral nerve block was continued until discharge. So in our case, the total knee arthroplasty underwent regional anesthesia, was successful with a hospital stay of no complications and good outcomes regarding the prosthesis. So there's no studies that evaluated the incidence of neurological sequels after the femoral, sciatic, and multiple cutaneous peripheral nerve blocks that were similar to the technique used in this case. So this case, it highlights the potential benefits of using the regional anesthesia as an alternative for those who cannot undergo any other type of anesthesia. So one of the limitations of this peripheral nerve block that should be considered is that in this case, the total dose of local anesthesia was used and the technique, it requires multiple separate needle entry points, and this could cause perineural, this needs multiple perineural injections. So the one last thing is that the innervation of the knee is highly variable, which could make the complete surgical anesthesia a bit difficult alone without any other modalities. So this shows that, or to conclude, with excellent anesthesia care, such complex cases can be managed through a patient-tailored approach as done in this case. So it was due to the patient's past medical history that involved multiple comorbidities. The total knee arthroplasty was done under regional block, and the outcomes were successful with no complications per se. And these are my references. Thank you.
Next slide.
Next slide, please. Okay, the outline of my presentation will be about definition of high-flow nasal cannula therapy, the differences in children, the important components of high-flow nasal cannula therapy, the working principles, the clinical effects, the treatment failure predictors, the escalation of care indicators, and the outcome. In this figure, you can see how the high-flow nasal cannula works. The definition is that the delivery of heated and humidified blended oxygen at optimal flow rates directly into the nares via a non-sealing nasal cannula. The most important components of the respiratory system in children is that the airways are very small and they tend to close. So our main job is to keep the airway open. Keeping the airway open, we facilitate the respiratory function, which together with airway production mechanisms, which are the cough and the mucociliary clearance, provides the better respiratory function through better respiratory compliance and less bronchospasm. Here we can see the consequences of the bad humidity. When the humidity is suboptimal, then there is an increase in infections, bad respiratory mechanics, the increase in worsening of breathing, and increase in evaporation loss. This is how the high-flow nasal cannula works. The working principles is that the system provides respiratory support. It's very comfort, and it provides maximal hydration. In this scheme, we can see how the system works, and it helps us to understand flows. many researchers have found that the optimal flow rate in children is to put the system at 2 liters per kilo per minute. And for example, we see here, if we talk about a 10 kilos child, then the optimal flow is 20 liters per minute. So the accumulation of flows produces positive pharyngeal pressure and increase the respiratory mechanics. And all this helps to unload the respiratory muscles and to decrease the work of breathing.
Next slide, please. Next slide, please.
Okay, here are how the pressures are accumulated, and you can see that when the flows are up, then the pressures go up also. And for example, when we are talking about adults, we can see that at flows of 60 liters per minute, then the positive pharyngeal pressures can be developed up to 6 centimeters of water. And this is very good because it produces a minimal effect of PEEP in the lungs.
Can the presenter make it into a full screen because we can't see anything? Whoever is presenting this presentation, please make it full screen. Good.
Okay, here we can see how the pressures in the pharynx are developed when the flows is 1 liter per minute and when the flows are 7 liter per minute. Here, when the flows are 1 liter per minute, in some instances the pressures are below 0, they are negative. While when the flows are more than 7 liters, then always at all the time the pressures are positive at the pharynx. And this is very good because this helps to keep the alveoli open.
Next slide.
So the development here in this figure, we can see again how is the during the inspiration. This is the respiratory cycle. During the inspiration, when we have spontaneous breathing, the inspiration phase is negative and the exhalation is positive. While when we use the high flow nasal cannula therapy, the pressures during the whole respiration is positive. Okay, and here you can see the differences. Here is when the patient is spontaneously breathing. This is from impedance tomography study. This is the area of the lungs, the cross-section area of the lungs when the patient is given only oxygen. And here you can see how much the area is expanded when the patient is under a high flow nasal cannula therapy, because the pressures, as we said, is during the whole respiratory cycle positive. And this helps to keep the alveoli open and to increase in functional residual capacity of lungs.
Next slide, please.
Okay, and here in the next figure, we can see how it helps to reduce the word of breathing, because here is the pharyngeal pressures in the upper part of the figure, and in the lower part is the esophageal pressures. When the flow is only 1 liter per minute, you see how deep are the esophageal retractions, and this means very high word of breathing. On the contrary, when the flows are higher, because the pressures are positive throughout the respiratory cycle, then the work of breathing is less.
Next slide.
Another important component of the respiratory support is that it produces a washout of and expiratory CO2, and in that way there is a reduction in dead space. Next. Okay. For example, here you can see in this left part of the figure, this is the CO2 levels. With the red are the higher levels at that expiration, which is around 5%. If the subject is breathing only through oxygen with low flows, at the end of the expression, there is CO2 accumulation in the hyper airways. When we use high flow, because of the continuous flow here, then there is a washout of the CO2, and you see that the levels of CO2 are low, so there is less rebreathing. And this helps to reduce the CO2 levels at the oxygen. Next, please. Okay, and another important component of therapy is that it produces exact amount of oxygen, because as you can see in the left side of the figure, when the patient breathes, for example, 10 liters per minute, because respiratory flows are much higher, then there is air entrainment in the mask from the environment, and the inspired concentration of oxygen is not accurate. On the contrary, when we use high flow, because the machine provides very high flows at exact oxygen concentration, then the concentration of oxygen given to the patient is more accurate. And this is very important for us. And here is again that to say that the machine provides optimal humidity to the airways, which is very good for the good respiratory function. The system is very comfort to the patient, because you can see that it is applied through very soft nails, and it doesn't produce any damage to the skin, because it's very soft silicone equipment. And it's very well tolerated from the patient. And also, there are studies, next slide, please, that the patient can also drink and eat during the high flow nasal cannula therapy. Here are studies in children and adults that says that the oral feeding and drinking is also possible during this kind of therapy.
Next slide, Eleni, every time you'll have to say that. You are not...
Okay, so here are the clinical effects. When we have this kind of therapy, then there is less tachypnea in the patient, less tachycardia, a decreasing rate of breathing, better oxygenation, better pH, and less carbon dioxide. And, okay, next. Talking about oxygenation, how can we see that there is an improvement in oxygenation? We can have improvement because we have better SpO2, less FiO2, better SpO2 to FiO2 ratio, with cutoff values for success between 195 and 212, better PaO2 per FiO2 ratio, with a cutoff value for success of 232. And in adults, there is the Ross index developed, which says that the ratio of SpO2 per FiO2 per respiratory rates, if it is more than 4.88 at 12 hours, then this means better prognosis, because these patients have less intubation and mechanical ventilation. In children, there is some differences in this index, but we can use also to see if the therapy is going well.
Eleni, every time you have to say next slide.
Okay. So, okay. Thank you. So, of course, generally speaking, this device reduces cost without negative drawbacks in the therapy. So you can see that it reduces neonatal trauma, it reduces intubation rate, it reduces clinical deterioration and treatment escalation, reduces PQ length of stay, and reduces PQ admissions and transfer. Next, please. Next, please. Okay, and concerning the safety of high-flow nasal cannula therapy, there are some caution about abdominal distensions, because the high flows sometimes can go through the esophagus to the stomach, And there are some cases of pneumothorax in the literature, which are about these cases you see. And that's why we should be very cautious when we use the high-flow nasal cannula therapy in the pediatric ward outside the PICU, where we should put lower flows at 1 liter per kilo per minute, compared to 2 liter per kilo per minute when we use the system in the pediatric intensive care unit. Next slide, please. Okay, so it's very important to have very close monitoring to the patient, especially during the first 60 minutes, because we have to decide if the system is going to success or not. So if we have a decrease in respiratory rate, it is an indicator of success. If we have a decrease in heart rate, it's an indicator of success. If we have less work of breathing, it's an indicator of success. If we have good oxygen saturation or less desaturation, then it's oxygen of indicator of success. If we don't have this green zone, then we should be very cautious to continue the therapy in the patient. Next, please. Okay, and then we should know when to escalate the therapy as doctors. So there are some criteria developed by the researchers. And these criteria are if the heart rate is unchanged or increased, this is the first criterion. If the respiratory rate is unchanged or increased, the second criterion. If the oxygen needs increased, the third criterion. Or if there is a triggering in the hospital internal early warning tool. This is the fourth criterion. If 3 out of 4 of these criterion are triggered, then we should escalate therapy to a more invasive form of mechanical ventilation. And in this study, which the researchers compared the high-flow therapy to the standard oxygen therapy, they found that escalation of care in high-flow, it was only 12% compared to 23% in standard oxygen therapy, which was statistically significant. And this is very important. And the other important thing is that 61% of the patients who failed standard oxygen therapy could be rescued with a high-flow nasal cannula therapy and avoid the admission to the intensive care unit. Next slide, please. Next, please. Okay, so we should be very close to the patient to have close monitoring, at least hourly at the beginning, because we have to recognize early if there is need for escalation. And from studies, it was found that the mean escalation time was about 6 hours after the initiation of the therapy. If things are not going well after 6 hours of approximately of therapy, then we should consider another mode of oxygen therapy to our patients.
You have to say next slide, please.
Yes, next slide, please. Okay, so this is about the treatment failure. There was about the treatment failures happens about 6 to 12 hours after the initiation of the therapy, and almost 3-4 of them happened after 12 hours to 24 hours. This means that in the first day of the therapy. So the treatment failure in bronchiolitis was about 3 to 23%. In bronchiolitis, comparing high-flow nasal cannula therapy to CPAP was higher. When we examined all causes of acute respiratory failure, it was higher. And the best performance was shown in pediatric cardiac surgery patients when they used the high-flow nasal cannula therapy after extubation to prevent post-extubation respiratory failure, where there was only 5% failure rates. The best performance was in these patients. Next slide, please. Next, please. Okay, and here we can see a meta-analysis of high-flow nasal cannula therapy, which says, generally speaking, that the high-flow nasal cannula therapy is better than standard oxygen therapy, but of course it's not better than CPAP or BiPAP, which are more invasive forms of mechanical ventilation and can provide more accurate levels of positive and expiratory pressure. However, next slide, please. Next, please. However, the most important question is not to compare the high-flow nasal cannula therapy with other modalities of respiratory support because they are not of equal capabilities, but to see what is the position of high-flow nasal cannula therapy at the timeline of respiratory failure. As we see in this conference paper, we can use high-flow nasal cannula therapy at the beginning of the disease and at the end of the disease, when things goes better. So we can have a continuous use of high-flow nasal cannula therapy this way to escalate the care, or in this way to de-escalate. Next slide, please. Next, please. So, in conclusion, high-flow nasal cannula therapy is an effective, easy, and gentle a way of oxygen therapy in our patients. And in Lancet, it was reported in an editorial that it would be a revolutionary form of oxygen therapy, which will be resembled to the era of SpO2 monitoring. When the SpO2 monitoring started some decades ago, no one could imagine how useful it would be in our clinical practice. In that way, high-flow nasal cannula therapy, and especially in the COVID area in our patients in the last 3 years, we saw how important is and how many capabilities has. Next slide, please. Next, please. Okay, so it's a very easy way of therapy, which can be applied according to the level of the disease, from the home to the pediatric ward, to the emergency department, and even to the pediatric intensive care unit to avoid more invasive forms of mechanical ventilation. Okay, next slide, please. These are my references, and thank you for your attention. And I'm sorry for the inconvenience caused by my system.
Eleni, don't worry about that. You are present.
And now in my report, I will touch on the problem of dysplastic change in vestibular site and how they can be represented to be associated with surgical intervention. Modern medicine tends to incorporate elements of globalized approach into the systematization of pathological conditions. While the synthetic processes are reserved for diagnostic and treatment, the above-mentioned tendency gave rise to the notions of chronic venous disease or chronic obstructive pulmonary disease, etc. Articular diseases make no exception. The group of scientists headed by Lidenham in 1992 designed that hip arthritis should be divided into central forms, you see, and superlateral forms. And these forms are divided such by the main vector of the loading. You see the dysplastic hip vector of the loading and the normal hip, but both hips on this picture are affected by hip arthritis. The most principal cause of superlateral form is dysplastic change of hip joint. We used FTCAR's classification for systematization of dysplastic changes of the acetabular site because actually we thought that it's more suitable and clear for this region. The aim of the study was to evaluate the X-ray parameters of the dysplastic acetabulum and visualize the defects regarding the results of the total hip arthroplasty. We have studied plain X-rays of 201 dysplastic hips. For the control group, you see here, we take 70 normal hips acetabular of patients with unilateral hips arthritis of non-dysplastic genesis. All of the patients in the main group have been subjected to an arthroplastic of the affected joints. According to the FTCAS classification, we have 68 joints type A, 58 joints type B, 63 joints type C, and 12 joints type D. Acetabular parameters were analyzed according to the plain radiographs of the patient pelvises with enlargement markers. The first parameter is acetabular width, you see, from A to B. It's the line which connects the most cranial and caudal acetabular points, exclusively ossificate, which fills the lower section. Ossificate we can see on this radiograph. This is ossificate, it's not true acetabular. Actually, acetabular width, which we can measure at the plain radiographs, does not correspond to the acetabular implant size in case of dysplastic hip arthritis. The next is acetabular inclination. It's an angle between acetabular width and horizontal plane line of the pelvis.
May I interrupt you, Tatiana, your video is switched off. We can't see you. Please switch on your video.
Depth, it's from its beginning, from C to D, to the bottom of the acetabular. And the next part of this record is acetabular bottom thickness, from D to E, from true acetabular bottom to the inner cortical plate of the iliac bone. And also we calculate a so-called acetabular index. It's the ratio of the acetabular depth CD to the acetabular width AB. The acetabular component implantation with restoration of femoral head rotation center due to the preoperative templating leads to appearance and limitation of the dysplastic acetabular defect. That one is the section delineated by the upper surface of the acetabular cup you see here, and the bottom sclerosed upper edge of the acetabular here. Then we insert acetabular cup to the acetabulum. This defect don't have lateral side. But we can calculate its area and its volume using only the plain radiographs. We propose both formulas for calculation of area and volume of dysplastic acetabular defects, and this computation as suitable for screwed acetabular cup or 10, which have a form like the truncated cone, and this calculation may not be so accurate for given spherical cups. The defect volume, which determines the amount of bone grafts, is calculated according to existing formula during the preparative planing of the optimal part insertion. However, its necessary parameters can be measured in advance. So by this formula, we can find amount of the bone grafts which we need to make grafting of the acetabular defect to prevent instability of the cup in the early and delayed period. Statistical result. Statistical analysis was performed with biometrics analysis and license software of Microsoft Excel and Statistica, and included instruments dependent on the type and distributional principles of data. The difference between values was considered significant if P was less than 0.05. All results are presented in this table, but then you see on this table you can't understand what's the tendency of the acetabular deformation we have. After analysis of this data, we find that the healthy acetabulum is nearly hemispherical, providing anatomical ground for implantation of breastfeed hemispherical cups in case of a primary hip arthritis. It should be also noted that the mean linear dimensions of the healthy acetabulum are relatively small, which explains why the cups of 50 to 56 millimeters in diameter are used more often. The smallest applicable size allows preserving the greater part of bone stock and its trabecular structure at the implantation site. Interplastic hip arthritis, acetabular shape change. Its growth from type A to type C, which might be attributed to the clinical displacement of the femoral head. During childhood and adolescence, before the growth plates close, acetabular roof becomes sloped due to eccentric femoral head pressure. Type D belongs to a separate category, being a complete femoral head dislocation, where both acetabulum and head are formed separately. In type D, acetabular width is very small, you see here. Due to acetabular roof destruction and the uppermost acetabular tips displacement upward, its medial inclination angle grows. Acetabular depth diminishes with dysplastic hip arthritis degree, while the bottom thickening increases. Acetabular index also diminishes from type A to C. However, in type D, it starts to grow. Thus, the acetabulum, which has never contained the femoral head, has more spherical shape when acetabulum affected by dysplastic hip arthritis of type C. However, these figures don't represent differences between the acetabular deformation times in a noticeable way, which is why we have decided to calculate. I'm sorry. Between acetabular deformation types in a noticeable way, which is why we have decided to calculate a percentage ratio between the normal and modified parameters. The healthy acetabular parameters were set at 1. You see it's the black color. And different types of dysplastic hip arthritis we make with different colors. And in this way we can see what parameters change in the most. As it was mentioned above, the increase of width and inclination is caused by the same process of skewing and destruction of the acetabular roof. However, in type A, the increase of width to 1.08 of the healthy acetabulum is associated with the increase of inclination up to 1.33 times at once. In types B and C, the difference between the parameters in relation to the healthy ones remains almost the same. In type D, there are an inverse correlation. Undeveloped acetabular walls lead to a dramatic increase of inclination paired with extremely narrow acetabular width. As to the depth and bottom thickness, these two parameters are also interrelated. As by adjacent sections the same line, furthermore, for healthy acetabulum and types A, B, and C, the sum of their absolute values is particularly similar. In this way, if one parameter diminishes, another one increased. In type A, bottom thickness makes 1.27 of healthy acetabulum. The maximum bottom thickness is observed in type C, up to 1.5 of healthy acetabulum. The depth is not significantly modified. In type D, the sum of absolute values is only 26 millimeters, while the bottom thickness is 1.4 times this healthy acetabulum value. This phenomenon gives rise to a method of successful acetabular component implantation due to resection of the thick bottom. Using this table, we can describe any dysplastic acetabular. You see lower bottom slide. The existence of the acetabular dysplastic defect depends on type of scar and increase with severity of deformation. In type A, the dysplastic defect is revealed in 58% of cases, in type B, 82% of cases, in type C, in 94% of cases, in type D, in all cases. The volume of defects and volume of bone graft for its filling shows the same correlation. You see from type A to type D, we need for most volume of bone graft to make acetabular cup stable. Conclusions. While acetabular dysplasia is progression, its deformation parameters are changing unevenly, even if they are interconnected. Acetabular inclination increases more significantly than acetabular width, even though the extent of deformation remains the same. The association between bottom thickness and depth allows the bottoms deepening out to correct position of implant's rotation center. Acetabular index with a complete subluxation is closer to a norm than with dysplastic hepatitis type C. A dysplastic defect occurs during the recovery of true center of rotation. Its extent and volume depend on the cranial position of the femoral head before the surgery. The suggested analysis of the third evolution according to X-ray data allows for the description of the defect and the choice of the optimal implanting technique. The method of defect evolution provides clear screening parameters of visualization requiring specification by precise diagnostic tools. However, without these parameters, it is impossible to evaluate the principal vectors and trends of diagnostic precision processes. Thank you for attention.
Dubai conference platform. Okay. Hello. That was a wonderful presentation. And now we have next in the order from Russia. We have a video. Can we see the video? The title of the video is Gene Expression Biomarkers in the Peripheral Blood of Osteoarthritic Patients for Postoperative Pain Predictor Prior to Knee or Hip Arthroplasty. We have Elena Shetina from Russian Federation. Yeah, you are audible and you are visible. Thank you very much.
Okay, and I'm going to tell you about the gene expression biomarkers in the peripheral blood of osteoarthritic patients for postoperative pain prediction prior to knee or hip arthroplasty. Osteoarthritis is a systemic condition that can affect single or multiple joints. It involves degenerative changes in the articular cartilage, remodeling of the subchondral bone, and limited synovial inflammation. Pain in OA is the main clinical symptom that limits patients' working capacity and everyday self-care. Osteoarthritic pain denotes an indication for joint replacement in patients with end-stage osteoarthritis. However, chronic postoperative pain is observed in 10 to 40% of patients with osteoarthritis. Mutative causes for the postoperative pain persistence are as following: predominance of central sensitization in 30% of patients with OA, dysfunction in the descending pain modulatory system, and altered expression of genes associated with neuropathic pain, such as cathepsin S, caspase 6, metalloproteinases 9 and 2, and tissue inhibitor of metalloproteinases, TIMP. Putative predictors of postoperative chronic pain are patients' socio-demographic and clinical factors such as female gender, older age, high levels of baseline pain, psychological factors like depression and anxiety, and various metabolic disorders such as high body mass index, obesity, inflammation, comorbidity, and arthritis in other joints. However, putative prognostic factors fail to predict the postoperative pain unequivocally. Therefore, molecular markers were identified we used the following methods. We monitored the vision analog scale index, brief pain inventory questionnaire to assess the severity of pain, the hospital anxiety and depression scale had questionnaire, and DN4 and pain detect questionnaires to assess neuropathic pain, the Western Ontario and McMaster University's osteoarthritic index, WOMAC, for functional activity assessment. 6 months after surgery, pain indices according to WAS of 30% and higher were considered. We also used the following methods. Protein levels were quantified by ELISA. Total RNA was isolated from whole blood, and quantitative gene expression assessment by real-time RT-PCR was performed for caspase 3, matrix metalloproteinase 9, tissue inhibitor of metalloproteinase TIMP1, cathepsins K and S, tumor necrosis factor alpha, interleukin 1 beta, and cyclooxygenase 2. We examined a study group which consisted of 50 patients with end-stage osteoarthritis of the knee who underwent total knee replacement surgery, average age of which was 67.6 years and range of 54 up to 82 years. The control group consisted of 26 subjects with average age 65.8 years with a range of 42 to 74 years, who were free from any serious diseases. "17 patients reported post-surgical pain 6 months after surgery. At baseline, both examined subsets of patients with osteoarthritis revealed essentially similar levels for the majority of indices. The only patients who developed post-surgical pain had more often arterial hypertension. Gene expression of cathepsin K and S, caspase 3, TIMP1, IL-1 beta, and TNF-alpha measured in the peripheral blood before surgery was significantly higher in these 17 patients compared to 33 pain-free patients with osteoarthritis. At the same time, MMP9 and COX the cyclooxygenase 2 gene expression was not significantly different in both subsets. The protein levels of TIMP1 in patients with osteoarthritis who developed post-surgical pain were significantly higher compared to pain-free subjects before surgery, while MMP9 protein concentrations were not significantly different between the examined subsets. ROP curve analysis performed confirmed significant associations between expressions of the identified genes in the peripheral blood before surgery with the likelihood of pain development after surgery. The cutoff values and were the highest in cathepsin S, and it had the highest area under curve. Therefore, high baseline expression of genes associated with extracellular matrix degradation, such as cathepsin S and K and TIMP1, inflammation, such as IL-1 beta and TNF-alpha, and apoptosis, caspase 3, measured in the peripheral blood of patients with end-stage OA before knee replacement surgery might serve as an important biomarker of postoperative pain development. Although previously knee and hip osteoarthritis were considered to be the same disease, some differences in pathophysiology were identified since recently. These are differences in inflammatory processes measured in serum or synovium. Distinct serum cytokines were differentially expressed between people with hip and knee OA, namely high concentrations of interleukin-4 and 10 and TNF-alpha were found in synovial membrane from hip OA compared to knee OA. And high serum concentration of pain biomarker COMP was associated with high hip-related symptoms, but not with knee-related symptoms. In addition, some differences in long-term prognosis were also shown. A shorter window of opportunity for non-surgical treatments due to earlier joint replacement in patients with hip OA was noted. Younger males with lower bone mass index more often undergo hip replacement. Greater patient satisfaction with hip replacement compared with knee replacement was observed. However, greater revision burden for hip replacement was also noted. Therefore, our specific aim was to identify genes whose expressions in the peripheral blood before hip arthroplasty could be associated with the post-surgical pain development in patients with end-stage osteoarthritis. The study group consisted of 31 patients with end-stage OA of the hip who underwent total hip replacement surgery with average age 61.3 years, with a range from 46 to 79 years, and control group consisted of 26 subjects with average age 63.8 years and the range of 42 to 74 years, who were free from any serious diseases. Twelve patients reported post-surgical pain 6 months after surgery. Both examined subsets of patients with osteoarthritis revealed essentially similar baseline levels for the majority of indices. However, patients who developed post-surgical pain had high bone mass index and neuropathic pain score according to DN4 questionnaire. Gene expression of cathepsin S measured in the peripheral blood before surgery was significantly higher in these 12 patients compared to 19 pain-free patients with osteoarthritis. However, IL-1 beta, TNF-alpha, and cyclooxygenase 2 gene expression was not significantly different in both subsets. The protein levels of cathepsin S in patients with hip OA who developed post-surgical pain were significantly higher compared to pain-free subjects before surgery. Rep curve analysis confirmed significant association between expression of cathepsin S gene in the peripheral blood before surgery with the likelihood of pain development after surgery. The cutoff value was 5.69 and area under curve was 0.741. Therefore, high baseline expression of cathepsin S gene measured in the peripheral blood of patients with end-stage OA before hip replacement surgery might serve as an important biomarker of postoperative pain development. Baseline expression of pro-inflammatory cytokines, interleukin beta, TNF-alpha, and cyclooxygenase 2 were not informative biomarkers related to postoperative pain development. We concluded that high prognostic value of baseline cathepsin S gene expression in the peripheral blood in patients with hip and knee OA indicates versatility of this biomarker in relation to surgery outcome expectations. Baseline pro-inflammatory cytokine, TNF-alpha and IL-1 beta gene expressions have prognostic value for postoperative pain development only in case of patients with knee OA. Baseline neuropathic pain scores have higher importance as prognostic biomarkers for postoperative pain development only in case of patients with hip osteoarthritis. Thank you for your attention.
You have exposed a very new front line which can predict the pain in patients undergoing total hip or total knee arthroplasty. I want to ask you a question, Elena, that you said that cathepsin S and TNF-alpha and interleukin-1B are the predictors of pain in the group of the patients who are undergoing surgery. So then, do you take care that these patients are given prophylactic analgesics, or do you keep, if at all you have given epidural catheter for the surgery, then will you give injections epidurally so that they don't get pain? Or what is the modality in which you can reduce the pain? Is it that you give a continuous morphine pump, or do you give pessaries, or do you give injectable analgesics for longer duration as well as higher dosage?
Actually, we studied the preoperatively the probability of postoperative pain development. Before the surgery, as I have shown, the pain was the same in the clinical during the clinical assessment. But if we know patients, if we predict patients who may develop postoperative pain, we should have to do special therapy, some special therapy preliminary for them not to develop this pain, either not to develop this pain, or just to change the method of their treatment, not to do operation with the same state of their health.
Thank you very much for your answer. And I am going through our list where I am getting a suggestion that who will be our next speaker.
Thank you.
We have from South Africa, Maspupse Fala. May I have Mafsuse Fala from South Africa, unmuted and with his video on. Mashupse Fala, are you there, sir?
I am here.
Wonderful, nice to see you. Now, three things I want to tell you. Your talk can be between 17 to 20 minutes. Please go with the full screen and left side bottom next to your mute, you have your video. Please switch on your video. Over to you now. He's going to talk to us about excess gait related lower limb fractures in children and adolescents, a review of injury patterns and evaluation of associated injuries. Please go ahead.
Can you see me?
All the next speakers, please understand, keep your presentation diminished, down, minimize it, so that we don't waste time in searching where is your presentation.
So in this talk, I'm going to present the background of the proximal humerus fracture, mainly in elderly patients, and how to decide for surgical management when to fix this fracture or to replace them. And at the end, I'm going to show you how we fix the tuberosity around the arthroplasty stem. I don't have any relevant disclosure to this presentation. So as far as we know that the proximal humerus fracture is very common in elderly people. Fortunately, a majority of them is minimally displaced fracture, which can be treated conservatively in a form of early mobilization and physical therapy. The challenge is the 3 and 4th part fracture dislocation, which occurs in elderly active patients with marked tuberosity displacement or severe angular deformity with dislocation or splitting of the head fragment. Specifically talking about the greater tuberosity displacement more than 5 millimeter or cranial displacement to the superior most aspect of the articular surface. So the surgical management options available range from percutaneous fixation to assisted arthroscopic assisted techniques, plate and screws fixation or intramedullary nail, and we have the arthroplasty option as well. Unfortunately, in 3 and 4 part fracture dislocation of the proximal humerus, there is no surgical management which can be identified according to the pattern of the injury. And this causes a surgical challenge when we're deciding which option is best. These are the factors which may influence our decision. The most important is the age of the patient. If the patient is elderly, above 65 to 70 years, the bone quality, do we have a good bone to support the fixation? And the humeral head, if it is still viable. And again, the fracture pattern may give an idea if this will be stable enough after the reduction and the fixation. And the last factor is the timing of the surgery, if it happens before or after 4 weeks. So in case of 3 and 4 part proximal humerus fracture in elderly people, the question is, when do we need to fix these fractures or to replace them? So usually we reserve the option of fixation for 3 and 4 part fracture with marked tuberosity displacement or severe angular deformity in active patient with reasonable bone quality to hold the fixation, and we are ensured that the humeral head is still viable. But the reported complication rate after fixation was up to 49%. This is mainly the varus malunion, which happens after the fixation, which is up to 16%, AVN of the humeral head, and screw penetration, and to lesser extent, the subacromial impingement and infection, which is about 4%. Loss of fixation occurred in about 3 to 16% in the literature, with a very high reoperation rate, which is about half of the cases in some studies. So for better outcome of fixation, apart from the proper indication and the preoperative planning, we have a lot of pre-contoured proximal humerus plates available. We should understand the function of this implant. We make sure that we have good exposure and proper intraoperative management in case of imaging. And the most important is the placement of the plate itself in terms of height and the calcar screw. Sometimes we may need to use supplemental fixation methods like bone graft or fibular bone graft. Other than that, we have the option for shoulder arthroplasty. So usually we keep this option in cases of poor bone quality with potential loss of fixation. If there's risk of non-union, and we know that group of patients, they have a lot of comorbidities and risk of non-union. And if we have a concern about the viability of the humeral head and risk of osteonecrosis. This is a study done by Herzl, which gives like predictive factors for the humeral head ischemia, mainly radiological findings like the posterior medial metaphysis fracture extension less of 8 millimeter and disruption of the medial hinge by mean of displacement of the humeral shaft by more than 2 millimeter. So intact medial calcar of the humerus is necessary for stable fixation. So the option of shoulder arthroplasty, we have the hemi-arthroplasty and the reverse shoulder arthroplasty. As we know that near in 1970 introduced the hemi-arthroplasty as primary treatment, and in his series it shows excellent outcome in about 90% of the patient, but these results couldn't be replicated later on, and consistently the hemi-arthroplasty showed poor outcomes. The problem with the shoulder hemi-arthroplasty is technically challenging because it depends on the intraoperative restoration of the anatomic humeral head, humeral height, the humeral version, and the tuberosity reconstruction. So the results are largely influenced by the tuberosity position and healing. This is a cadaveric study done by Frankel 2001, which showed the tuberosity when malpositioned, there's 8-fold increase in the torque required to achieve the same degree of external rotation. And many clinical studies have shown poor outcome when proximal humerus anatomy was not restored. This is the unhappy triad of Pascal Ballou, 2000, mainly about the humeral height and retroversion. So in this study, it shows that combination of excessive prosthesis height and retroversion resulted in persistent pain and stiffness in all the cases. Another study done by Kaf and Bablu in 2013, and he had compared the hemiarthroplasty with healed tuberosity and the other group with tuberosity resorption. The healed group showed a good functional outcome and range of motion in almost most of the cases. So for better outcome of the shoulder hemiarthroplasty, we should make sure that we recreate the proximal humerus anatomy in a perfect way. This is a concept, the Gothic arch reconstruction, which stated by Summit in 2008. And this is how we should create the prosthesis height and version. In his method, he used the other normal shoulder, which he thought that this is a healthy shoulder, to measure the height and the version of the proximal humerus. But as a general rule, the greater tuberosity should sit 3 to 5 millimeters below the prosthetic height in the hemiarthroplasty. So the results of the hemiarthroplasty for displaced 3 and 4 part proximal humerus fracture, mainly in elderly people, have been disappointing and unreliable. And as you said, this is for the technical challenge as largely influenced by tuberosity position and healing, and again, associated comorbidities of the elderly people, which may enhance non-union, and inability to comply with rehabilitation, and again, the mixed clinical results, which have been shown later. So the reverse shoulder arthroplasty has emerged as an alternative option, and it shows a good functional outcome because it's less dependent on the tuberosity healing and the rotator cuff integrity. So even in the absence of the tuberosity healing, the patient remain able to elevate or abduct the arm or both of them, and this is very important. So these are studies between the RSA, the reverse shoulder arthroplasty, and the hemiarthroplasty, which showed a good functional outcome after the RSA group. This again, a study between the two groups, which shows a good functional outcome and range of motion after the RSA group. However, in the preliminary data, it suggested that the tuberosity malunion or migration after the RSA group, which it kind of care up to 50%, restoration of the external rotation strength is rarely achieved. And this making all the activities of daily living difficult, if not impossible, for the patient. So this is a paper by Pascal Ballot, who compared the healing of the greater tuberosity after the RSA group. So in the anatomically healed greater tuberosity, it shows that there are better functional outcome, mainly in the constant score. And if you look here, the mobility arm of the constant score is improved much compared to the migrated or resorbed greater tuberosity. And the range of motion significantly improved in the anatomical healed group. Pascal Ballot showed that the rates of the tuberosity healing vary between 40 to 80%. These are the numbers reported in the literature. We did a retrospective study for displaced 3 and 4 part proximal humerus fracture dislocation in elderly people. We had 48 patients with 49 shoulders. All of these patients treated with reverse shoulder arthroplasty using a modified technique. The average was 71 and follow-up 24 months. So in this case series, it shows the healing rate was 86%. We had the complete resorption of one or more tuberosities occurred in 8%, and tuberosity migration, non-union, occurred in 6%. So this is the principles how to fix the tuberosity around the arthroplasty stem. So we have 3 sutures: the horizontal tension suture, which connects the greater and lesser tuberosities together, and the vertical tension suture, which connects the tuberosities to the shaft, and lastly, the circular suture, which goes around the stem and the 2 tuberosities. In our department, we do Tanaka technique for tuberosity repair. It's easy and reproducible, and we don't need like any special implant. Any conventional humeral system can do the job. And we believe that it adds more rotational stability to the construct. This what we need to use for this technique. So usually any braided non-absorbable suture can do the job. We use modified Mason-Allen suture technique, and we use loop BDS just to shuttle the cerclage suture around the implant. And as I said, any arthroplasty stem can do the job, especially if it got this inferior medial hole. So as far as I know, most of the arthroplasty stem available in the market, they got this hole inferior medially. So here I'm going to describe the Tanaka technique. This is a right shoulder with 4 parts fracture. So in the clinical photo in the left, we see here we are preparing the fracture. We got the GT on our left hand and the lesser tuberosity in the right hand, and holding the biceps with the cocker. So we started with the vertical suture. This is a high-fi suture in the lesser tuberosity. In the second image in the middle, we put another suture in the GT. And if you look at the image here in the right, we drilled 3 holes in the bicipital groove, and we believe that this is the most tough part of the bone, can hold the suture. And we put 2 high-fi suture. This is for the vertical tension suture later on. Step 2, we start preparing all the sutures. So in the diagram on the left, you see here we're passing 2 loop BDS. The first one, as in the clinical photo in the top, we pass the needle from outside to inside in the greater tuberosity, and usually here in the junction between the infraspinatus tendon and the bone. The clinical photo here on the bottom, we pass the other loop BDS, and this is a trick here. We pass it from inside to outside so that later on we can do the cerclage. So the final suture preparation will appear here in our in the diagram on the right side. We have the 2 loop BDS and the high-fi suture for the vertical and horizontal tension. In the third step, we'll start doing the cerclage and shuttling the ribone around the implant. So we start from the greater tuberosity, and we shuttle the ribone from behind the humeral system, and it goes through the inferior medial hole, and we use the other loop BDS again to shuttle this ribone from inside the lesser tuberosity to outside. So this is how it looks live. In the starting from the left, we have the loop BDS pass through the inferior medial hole. In the second image, we passed the ribone around the stem, and in the third photo we have here, this is a loop BDS in the lesser tuberosity, and we pass the ribbon, getting it from backward to forward. So after we do our trial, and we make sure that the two tuberosities will be reduced nicely around the stem, when we put our bone graft, we start closing the book. So we tension the vertical suture and we make a knot, and after that, the ribbon on top of that. So we have a good construct around the proximal humerus. And the good thing about this technique is we control the rotation, as we know that the ribbon is passed through the inferior medial hole in the stem. Lastly, we start our vertical tension suture. And in this technique, we use to tie the vertical tension in a cruciate manner or figure of 8. So we take a suture from each side and we tension it to the other side. After the end of the operation, usually we take an intraoperative image, like one shot of X-ray, and this is how it looks after the greater and lesser tuberosities fixed around the proximal stem. This is a case of non-union. This is a post-op X-ray after 2 years. And this is a case of tuberosity resorption. Again, this is about 2 years after post-op, and we see that the greater tuberosity is completely gone. Thank you very much, and I'm happy to take any questions.
Dr. Ahmed Hegnasir from UK, your presentation was very well explained, in which we could see most of the things pretty well. If there is a video, if you can send to the organizers, we'll be able to appreciate it much more, and we'll make sure that everyone receives that video of yours. My question is, how do you decide to do reverse shoulder arthroplasty? Just glaring indications, because reverse shoulder arthroplasty has been in vogue for quite some time, and without looking into the matter, whether the external rotators are functioning or not, the younger community wants to do RSA. So can you please give clear guidelines when it should be done?
Okay, so this is a good question. Usually we reserve the arthroplasty option, as you said, for active patient with 3-4 parts fracture dislocation, when we think that the head is not viable and there's a chance for osteonecrosis. So we use this technique for both the hemiarthroplasty and the RSA group. But usually we prefer the RSA group when we are not sure that the tuberosities will be reduced nicely around the stem, because the hemiarthroplasty outcome is dependent on the tuberosity, on the anatomical restoration of the proximal humerus. So if we are not sure that we can create this exactly in anatomical position, we go for the reverse shoulder arthroplasty. The reverse arthroplasty is less dependent on the anatomical healing of the greater tuberosity in terms of forward elevation and abduction. But we know that restoration of the external rotation has been associated with better functional outcome. So I agree with that. Nowadays, we have a tendency to go to RSA more, because the literature shows that there's improved outcome, and the hemiarthroplasty group, which shows like an, I would say, inconsistent results in the literature.
Thank you very much. And we have now Madhvi. Kamela from UK. Madhvi Kamela, please unmute yourself. Switch on your video. Madhvi Kamela. Madhvi Kamela, are you there? Please unmute yourself. Emily, is Madhvi there or not? Is Madhvi there?
Type of cementerial total knee prosthesis components in an Ecuadorian population. This study carried out at the Eugenio Espejo Specialty Hospital. This is one of the largest hospitals in my country, in Quito. The study was made at 2016 year. The objectives of this surgery was eliminate pain and recover joint mobility and recover muscle and ligament function, okay? Remember that we want to replace worn joint surfaces with external components. Some historically facts. Bernouil was the first that made interpositional arthroplasty with joint capsule. After Campbell interposed free fascia transplants, Smith-Peterson, and 1942 used some metal model to cover the femoral candiles, and Valgus and Shears used a prosthesis for both joint surfaces, providing stability and alignment. Gunston, in 1971, used a prosthesis of low friction steel against polyethylene cemented to the bone. Remember that the knee is a load-bearing joint subjected to trauma, and the overloads and repetitive movements cause wear in the joint. For treat this pathology, the surgeon must know the anatomy and the biomechanics of the joint, and remember that the size influences in post-surgical results and functional evolution. We do not underestimate the limited mobility and chronic pain after these surgeries. In my country, the gonarthrosis is a common pathology, and the knee arthroplasty surgical team of Eugenio Espejo Hospital in Quito want to define the size of the knee prosthesis. The objective of our work was determine what is the usual size of cemented total knee prosthesis components in Ecuadorian population. This study was made from January to December of 1916. This was a descriptive cross-sectional and retrospective study. And we include 74 patients with gonarthrosis 3 and 4 grade, confirmed clinically and with Kilren and Lawrence classification. It was standardized and the most used sizes were determined. At the results, 76 patients underwent surgery, 58 was feminine, and February and November had the greater reach. We can see on the table that in February, we take 15 patients, and in November, another 15 patients. The prosthesis with knee pathology is common in people over 65 years. The knee joint replacement is growing. Remember that at 2020, the casuistic was doubled. And